allogeneic natural killer cells are safe and active in a variety of hematologic malignancies. Well, we know that, but what about multiple myeloma? Someone has been working on this now for about 10 years. So let's talk to Dr. Nina Shah, who is an associate professor at the University of California in San Francisco. Now, let's start with the science, because allogeneic stem cell transplantation we're all familiar with, it's been used. But here we're talking, the focus is on allogeneic natural killer cells.
Correct.
Where did this come from? It's a great idea.
Well, we know that many of the malignancies, particularly in the case of multiple myeloma, are susceptible to immune-mediated therapeutics. And we've seen that with antibodies and now with T cells. And we were interested in the possibility of allogeneic cellular therapy against myeloma because of our experience with allogeneic transplant with myeloma, which isn't what is standard of care, but there are a few patients who have had long-term remissions, and we think that might be related to an immunologic graft versus myeloma disease, effect. And that's why we wanted to use allogeneic immune effector cells, and we were particularly interested in NK cells because they seem to be safer and they kill, that's what they're supposed to do, right, without causing graft versus host disease.
Well, but then of course you're talking about sourcing and then large-scale expansion.
Right.
So where are you getting these?
So unlike what a lot of allogeneic cell therapies have been from, which is peripheral blood, we were interested in looking at umbilical cord blood, which is a very well-known source of hematopoietic cells, and we know that there are cord blood transplants. But we started to realize it was a great resource for immune effector cells. And when I was a fellow, we started a project to see if we could actually clinically expand these NK cells from cord blood. We were able to do that and show that they reacted against myeloma.
So you have, that's the phase 1 data you published in the British Journal of Hematology?
Right, and even before that we had to publish the bench research, which was actually in PLOS One. So that all started when I was a fellow, and then we published that data, then we did the phase 1, which was published last year in British Journal of Hematology, and now we have the phase 2 data.
So this is phase 2, we're here at ASCO, and it's a relatively high-risk MM population.
Yes. About 3/4 of the patients had some sort of high-risk feature, including ISS stage 3, or an adverse cytogenetic or FISH characteristic, or also have had relapsed or progressive disease. So that's higher risk than we normally would have going into transplant.
So what are you reporting here?
So we're really reporting the response rates. Our study was looking at greater than or equal to VGPR rates at day 100, and we were reporting some duration of response. So we were able to show that the best response of 79% of VGPR or better was reached, which was actually very good in this patient population, although there is transplant involved, and I don't want to make too much of just the cells, but it's likely in combination. And we actually had MRD negativity by a 10 to the minus 5 sensitivity flow assay at 61% of the patients. So that was actually also great.
And you also included lenalidomide first for a week and then a couple of days after starting the IV methylene.
Correct.
And that's mostly because what we've seen in combination with the lenalidomide is that it actually could work even better.
Right. We had some preclinical data in the lab to show that small amounts of lenalidomide actually increased the NK cell function. And this is thought to be true with lower doses of lenalidomide. So we did what we call immunomodulatory dose of 10 milligrams a day for 1 week during the time that the patient was getting both the melphalan and 2 days later the NK cells. So we let them incubate together for a little while.
And so then 5 days later after the cord blood natural killer cells, the autologous peripheral blood progenitor cells were infused.
Correct, and which is a standard sort of stem cell transplant platform, but we inserted that NK cell and lenalidomide part in there.
In terms of safety, what did you find?
Well, actually, it ended up being fairly safe. There were no infusional toxicities. None of the patients had GVHD. We did not see any CRS or cytokine release storm or cytokine release syndrome, and we did not have any neurotoxicity. So the cells were okay. We had been concerned about possible graft rejection, meaning that these cells would come in and kill the autologous graft. And one patient did have a failure to engraft, but we later found out it's because her cells had been poorly stored and they had low viability to begin with. So she was rescued with an autologous backup graft that she had already collected. So that ended up not being an issue. But everybody else did fine. We really did not have very sizable toxicities that we were concerned about. Now, we don't know if that's good or bad because sometimes you like to have cytotoxicity.
Exactly. So what did you find? So what do you think the future is for this?
You know, I think that this was a project that we were really interested in developing to try to develop NK cell therapy, and myeloma seems like the perfect place to do that. I think that we still need to modify the NK cells, particularly to increase their persistence. Although we were able to detect them by a microsatellite chimerism assay in the recipient, sometimes up to 1 to 2 weeks after infusion, they generally went away after that time. And I think that if they're going to act against myeloma, particularly for a few months out or a few years out, we need to see if there's a way that we can get them to sort of self-sustain without being rejected by the host immune system.
So you're going to continue working on this?
Well, I'm not at MD Anderson anymore, so that makes it tough to work there, but or work on it. But that project is being continued by my collaborators that are still there.
It should be fun. I mean, sounds like a fascinating particular area of expertise.
It's
that you
really
have.
exciting, and I think all cell therapy is super exciting. And 10 years ago, this was nothing. When I first started this project, which was 10 years ago this month, people really laughed at me, really. And now it seems like something people are interested in. I'm so excited not only for our community, but for our patients who are actually so much more interested in immunotherapy and willing to enroll in clinical trials and be part of this movement so we can really figure out how to cure this disease.